Good morning, everybody, from Miami Beach. We're starting in a few minutes.
Good morning, sir.
Good morning. Oh, Zanab, how you been?
I've been doing fine, sir. How are you?
Good, good. How are things in Africa?
No, I'm in Moscow at the moment.
Oh, okay,
I'm still here.
good. Welcome. How much nervous is everybody? Is he coming in or not? They had problems a couple of weeks ago. Good morning. Hi, John Bennett. Welcome, everybody. We're just waiting for Ben and Juan Lee. I hope you're coming in. Hello, Martin. Saeed, I'm trying to get you in there.
Okay.
Have you talked to Juan Lee lately? Hi. They had trouble, I think, with the link last week.
So if I do this, do you hear me?
Yes.
Okay. Welcome, Dr. Sheikh. He's also, I met him in some meetings in Istanbul way back when.
Oh, Martin. Martin, how you doing?
I'm fine, thank you, John.
Yeah, I recognize the voice. I don't see your face there.
Oh, right, but let me switch on. I have a camera now here.
Yeah, you can put a camera on.
There you go.
And you can meet people here on the panel.
Right.
Everyone, this is Martin.
Hello.
He's done some extensive traveling. I know that. Why don't you tell about yourself, Martin?
Well, I trained for a start in Switzerland with Professor Yasagil at the time, and then he was not always an easy man. So I decided to do some training in New Zealand. So I went to New Zealand, and later on I went to Toronto in Canada to do some skull-based training with Fred Gentili, who passed away last January, actually.
Oh, okay.
So that's in a, and then I worked in the Middle East as well. So yes, and in Switzerland for many years.
Okay, let me spend a few minutes and try to track the gentleman down.
Dr. Sheikh, how are you? Okay. كيف حالك؟ الحمد لله.
More folks. Just trying to get through. Okay, you know, okay. come the screen is stuck here? Okay.
Desde
Okay.
la 1 de la mañana habla
Yeah,
ya.
Dr. Sbeih, I think we'll start. I think there may be connection problems there. And I think Ben will join us eventually. Okay? Okay, you're muted there, Dr. Sbeih. Okay, 10, 9, 8, 7, 6, 5, 4, 3.
Good morning, John.
2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach here. We have the bi-monthly Chinese Neurosurgical Journal webcast scheduled. Ben is having I think we're having problems getting Ben in, but he'll join us eventually. We have honored with the presence of well-known Jordanian neurosurgery educator, Ibrahim Sbeih, who we did some grand rounds a good while. He showed us off his knowledge and his country, and we welcome him today to present radical excision of craniopharyngiomas. Welcome back, Dr. Sbeih.
Thank you very much, John. Okay, can you see my slides?
Yes, perfect.
Okay, thank you very much indeed, John, and thank you for the invitation. My name is Ibrahim Sbeih from Jordan, and this is the Rahma Medical Campus where I work. And I'm going to speak today about radical excision of craniopharyngiomas. Before I do that, I always start with my country. I love my country. I'm proud of my country. I'd like to present some of the slides from my country. This is the Dead Sea, the lowest point on earth, where you just swim and float on the top of water. And this is the site of the recognized baptism site on the River Jordan, visited by late Bob. This is Mount Nebo. This is Jerash, the Roman amphitheater and antique city, second only to Rome. And there is a musical festival every year in Jerash. Petra, the jewel of the crown. And the countryside of Jordan, which people don't recognize that we have a beautiful countryside here. And this is the black iris symbol of Jordan. And this is my home in Amman, Jordan. This is in summer. And this is in winter. We have snow every year. The first neurosurgeon in Jordan was Anton Tarazi, who started practicing neurosurgery in Jordan in 1961. He graduated from the American University of Beirut. He trained in Montreal, Neurological Institute there under giants of neurosurgery like William Cohen, Penfield, and others. And he came back to Jerusalem back in 1961, where he established the first neurosurgical unit in Augusta Victoria Hospital in Jerusalem. Jerusalem was then part of Jordan, the West Bank of Jordan. Indeed, in 1966, he held the first Middle East Neurosurgical Congress back in 1966. He died in 1999 when he was doing his last surgery, actually. Look at this by John Jane, the senior, wrote this paper, and he was one of the associates of Dr. Tarazi. He says, I have remained grateful for Dr. Tarazi's dedication to teaching, and his influence has continued throughout my career. So I'm proud to hear this from John Jane, the senior in Virginia. Dr. David Hania of Jordan started open heart surgery back in 1972, making Jordan on the medical map of the world in cardiac surgery. And he actually performed the first heart transplant back in 1985. The first CT scan in the area was in Jordan back in 1978. And the first IVF baby was back in 1986 by late Dr. Zaid Kilani. The first aneurysm to be coiled was back in 1999 by Dr. Hazem Haboub, Jordanian doctor, under the supervision of Jack Murray. And skull-base surgery started very much early back in 1985. We used the sitting position a lot. And the first gamma knife in the region, making Jordan number 13 in the world in acquiring this technology back in 1996. And this is me back in 1996. Robotic surgery was started in Jordan 2002. We use the latest gadget of neuronavigation and observation, etc. We established our cadaveric lab, and this is actually my daughter in the lab. A lot of people from around the surrounding Arab countries and the whole world came for this cadaveric lab, and we had very successful courses. This is Vinko Dolens, and this is Ali Krecht doing their teaching on the lab. This is the Jordan Neurosurgical Society back in 1983. About 25 people were there. Now we have more than 120 neurosurgeons for a population of 10 million, which is very good percentage. We practice every subspecialty of neurosurgery, cerebrovascular, skull base, everything. And we empower people to go to neurosurgery. This is my daughter who finished her board of neurosurgery, and she spent some time training with Professor Majid Sami in Hanover. All of the giants of neurosurgery actually visited Jordan, almost all. Charles Drake back in 92. Is Jill? Johan, which you all know. Lindsay Simon. Albert Roten. Majid Sami. Robert Spitzler. Hirohito Sano from Japan, Yoko Kato, Professor Takeshi Kawase, Professor Tetsu Kano, late Professor Tetsu Kano, Vinko Dolens, who also held a course in the cadaveric lab, Mark Sindau and Jacques Brocci from France and Belgium, late Athos de Souza, Edward Lowe's, Nelson Oseko, late Eduardo Rivera, Sam Al-Mifti, Eliam Shaker from Seattle, Ali Krecht, Little Rock, Arkansas, and all the endoscopists, including Enrico De Vitis and Paolo Capabianca, Atul Gowel Tour from Turkey, Maurice Schukes from France, William Caldwell from Salt Lake City, United States, Axel Berneski, late Axel Berneski from Mainz in Germany, Rudolf Falbusch from Germany, who's practicing now in Hanover. He visited Jordan. Engelbert Knosp, known for the Knosp lines, the pituitary. Dr. Daryl Brackman of the Brackman and House classification. And of course, the WFNS held their meeting here in Jordan back in 2004, and I was then the vice president of the WFNS. And this is members of the World Academy of Neurosurgery, including myself. I did visit China. This was the skull-base meeting back in China. And I was impressed with the facilities, with the medical education, and was also impressed with the hospitality and kindness of the Chinese people. And I actually brought my son with me that time. So I had a very good time in China several times. My colleagues also in China. And I remember these two guys, this boy and this girl, who were assigned to accompany me wherever I go for facilitating things for me, and then they took me to the Great Wall of China. If they see their images during this meeting, please call me and get in touch with me. I want to thank them again. So this is the Great Wall of China. the museums, the very beautiful Chinese towns and cities, and the very wonderful Chinese food. So back to the radical excision of craniopharyngiomas. Still, there is a debate. Should one go for partial resection followed by radiotherapy, or should one go for radical resection? I subscribe to this. I don't subscribe to this. I go for radical resection because there is less recurrence, less procedures, and no complication of radiotherapy. Let's look at this. In many parts of the world, including the Arab world, the world in large, in Asia, Africa, everywhere, the major lines of management for craniopharyngiomas are: they puncture the cyst, they put an Omeya reservoir, they go for shunts with minimal resection followed by radiotherapy. This should not be on. This is a bad practice. I've been fighting all my life against this primitive manipulation of craniopharyngioma. Let me convince you. Ed Lowe's, back in 2012, described this expert opinion. And he was describing a 4-year-old boy who 92 had craniopharyngioma, right VB shunt, left VB shunt, biopsy aspiration, revision PD shunt, craniotomy for partial resection, radiotherapy, still the same, 97, craniotomy for recurrence, 99, another recurrence, given gamma knife, 2000, he had major recurrence, they refused surgery, he died. This is the common thing. This is, unfortunately, a case history like this is very common. I'm not saying this, Ed Lowe's is saying this, and he's the expert in pituitary and craniopharyngioma. So let's look at, is he alone with this, or there are major surgical series? There are. You just can't read, but I'm just put them to show you that I have collected major series who go for radical excision. And let's take some of them. Yazergil back in 1990, 90% excision. Kemp, 100%. Zhang from China, 91% excision. So Yazergil, Falbush, they have done, like Yazergil, 144, 90% excision. Falbush, 94, 90% excision. Souza, 83. Tomita, 80%. Zhang from China, as I said, 91. Bischoff from New York, 94. Kim, 100%. Let me take you back memory lane to convince you that people were going for radical excision back in the 70s when we did not have CT and MRI and nothing of that sort. Why are we now doing the things that people actually have done successfully back in the 70s? This is Harold Hoffman, the major pediatric neurosurgeon from Canada, back in 76 with the primitive images and primitive microscopes and so on. 20 out of 29 had total removal with no recurrence. Is that not convincing? Okay, 85, Osama al-Mufti had 20 cases of giant. Look at this, giant. Majority of these lesions can be safely removed. Osama al-Mufti again, total removal of giant craniopharyngiomas. He says, a gliotic layer usually exists between the tumor and the functioning wall of the hypothalamus. So stop telling people that you cannot excise the craniopharyngioma. Yazergil, back in 1990, the best long-term control can be achieved by complete removal of the tumor at the initial presentation. Don't go for biopsy, go for radical excision. And he showed this in his series. 144 patients. Carmel in Yeoman's book says this: we advocate radical resection as the optional treatment in all patients, especially in young children. And he would state this very, very important message. Incomplete section is a virtual guarantee of recurrence within 3 years. Don't go for biopsy and radiotherapy. Another paper from France on 122 surgical cases, and the conclusion was radical surgery gives better outcome of survival, full recovery, and quality of life for both adults and children. It goes again back from my clinic, attempt at radical removal of the tumor should be considered even for recurrent. So even if you have recurrence, go for surgery, not for biopsy, not for radiotherapy. It goes again from my clinic, non-surgical options like radiotherapy, radiation, chemotherapy, whatever, should be reserved as adjuvant therapy following surgical management, not upfront therapy. Farbush from Germany and now in Hanover, radical excision of 94 cases with long-term good social functionality. I'm trying to convince you that the good surgeons, the giants of neurosurgery, are going for radical excision and not for biopsy and radiotherapy. Another paper from Farbush, 73 patients had gross total resection in 89%. From Slovakia came Stino. This man changed our concept about the management of craniopharyngiomas, and he says this unequivocally: the final decision about the optimal extent of a tumor should be done during surgery. So don't look at this and say, oh, this is giant craniopharyngiomas, I'm just going to go for biopsy. It cannot be removed, so I'm just going for biopsy and radiotherapy. Decide when you go in, because you'll be surprised that you can actually achieve radical excision from this. Looks like inoperable case. So Stino from Slovakia and another man from Pascal from Spain also reported this paper about how the tumor pushes the mammillary bodies laterally. So don't be worried about the hypothalamus that much. You can achieve good results. So Pascal again on 500 tumors, he looked at the different types and the classification of these tumors. So Pascal and Stino really changed our concept of craniopharyngiomas. From USA, Tomita, total resection provided the best outcome. It looks awful, radical excision, transventricular. And they advise, even if you have recurrence, first surgery, recurrence, second surgery, recurrence, third surgery, don't send for radiotherapy unless it is just a terminal case or final case or adjuvant therapy for symptomatic treatment. From Argentina, I'm just showing you papers from all over the world: France, USA, Japan, China. From Argentina, radical resection of craniopharyngioma. It looks formidable. Sami from Hanover, gross total resection, 64 out of 65. Christian Saint-Jean Rose from France, he's a major pediatric surgeon. The best overall result is achieved with complete resection by experienced craniopharyngioma surgeon. So craniopharyngioma should not be given for the uninitiated or for the neurosurgeon who has no experience. You have to have good experience to go for craniopharyngioma. It's not for the amateurs, it's not for the beginners. From China, Zhang, total removal resection is feasible with the preservation of final structures with lower recurrence rate and low morbidity. This is a report on 309 cases in China. Jeffrey Wusser from New York, we believe that radical resection at presentation offers the best chance of disease control. Are you not convinced enough? Let me proceed. From Korea, is complete resection of craniopharyngioma in adults feasible? The answer is yes. Complete removal at first surgery provides the chance for cure. So we're not just looking for any treatment, we are looking for a cure. This is stereophosic craniopharyngioma kind of thing. Kenji Ohata, my friend from Japan, aggressive tumor resection should be the treatment policy. Mortini from Italy, radical resection is associated with the best outcome in terms of survival and recurrence-free survival. Do you need more? There is more. My clinic. Maximal safe resection via microsurgery or endoscopy provides a very good tumor control. So I'm not fighting should you go for surgery or for endoscopy. Whether endoscopy or microsurgery, the aim should be radical resection, not biopsy and radiotherapy. Okada had 81 patients and showed radical resection. Prostate resection in the United States by using the endoscope. So endoscopy series also showed they are going for radical excision. And my late friend, Fred Gentili from Toronto, microsurgery and endoscopy, he showed that also he goes and he used to go for radical resection. Another paper about endoscopy from Japan, 70 patients engrossed to the resection. So be it microsurgery or be it endoscopy, the aim is radical resection. So stop please doing biopsies and for radiotherapy. This is a crime against humanity as I can think. Paul Gardner, a good endoscopist from the States, showing that he achieved good result by endoscopy. Let me discuss with you some of the bad practices practiced around the world. They get a case of Craniopharyngioma, of course, causing hydrocephalus, and they go for shunting. Don't put a shunt as upfront treatment. If you remove the Craniopharyngioma, there's no reason, there's no cause to put a shunt. So what are you doing here? You joined and you put this shunt and then send for radiotherapy. Crime against humanity, still practiced around the world. Or this one, bilateral shunt. For goodness sake, what are you doing here? Another bad practice is to put Umayya reservoir again as upfront treatment. Who is Umayya? He's Ayub Khan Umayya, Pakistani neurosurgeon who immigrated to the United States back in '65. He was given the task of trying to put some chemotherapy intrathecal into the ventricle, and he invented this reservoir. Tube going to the ventricle, reservoir here, they inject the anti-cancerous and antibiotics through this reservoir. Back in '65, it was for cancerous patients, palliative treatment, still used nowadays, upfront treatment. Again, crime against humanity, for goodness sake. Why are you still using Umayya reservoir? It's not only me who's saying this. My clinic report to 2018, Umayya reservoir is palliative. It should never be considered as a first-line treatment. What more evidence do you need? So back to my series, just to show you that I subscribe to this policy of radical excision. My series is 114 cases, mostly children, 66 years, 2 years youngest, 76 years is the oldest, but most of the patients are at this range of age. My protocol for all cases is to do full ophthalmological assessment, including visual acuity, fields, fundoscopy, and OCT. We use the German visual field assessment, which combines visual acuity and visual field defects. We sometimes go for visual evoked potentials. And in my series, visual manifestation was a major one, whether in children or in adults. Full neurological examination, the signs here in symptomatology of the presentation was hydrocephalus in children, 22. So more hydrocephalus in children. Of course, the other manifestations are well known to you, hemiparesis, cranial nerves, etc. This is the pre-operative manifestation. And also pre-operative manifestations, we look for the hypothalamic functions. Do they have obesity? 12 of the children had pre-operative obesity. Remember this, if the tumor has caused obesity before you operate, most likely this obesity is going to continue, whatever you do. We also do full psychological assessment, including Karnofsky Performance Scale for all our patients except the very young. Full endocrinological assessment. In my series, we found that hypogonadism was 4 in children, hypoadrenism 8 in adults, growth hormone was more in children as expected, hyperprolactinemia 7 in adults. Partial hypopituitarism, whether partial or total, was more in adults, DI was more in adults. So images from my series, CT scan would show you the calcification. All the images I'm showing you are from my series. I don't take from other books or other papers. These are my series. So you can see the calcification very well. The MRI would tell you what to find. And this is the MRI of the 114 cases in my series, different shapes, different kinds. The alarming thing in my series is that the size of more than 4 centimeters, the so-called giant ones, were the majority, 74. Jordan is a medical hub in the Middle East, and we get those cases very late, very advanced, having giant size actually. And I mean giant like this, giants of giants. And this is just to show you the giants in the coronal section and in the sagittal section. So when I say giant, I do mean giant. And this is, of course, a major factor in the prognosis and the management. Look at this one, starting here from the foramen bone road down to foramen magnum, and this one. Oh, look at this one. Who would actually think that this is a craniopharyngioma, extending really back to the stereofossa? It was a craniopharyngioma, giant one, extending everywhere. 7-year-old. Angiography, the MRA or conventional angiogram will show you the details. CT angio here shows you the details and the calcification in one of my patients. MRV is a must. Again, you need to see what are you facing. I use many surgical approaches, subfrontal, terional, or interhemispheric. And the steps of surgery I'm going to show you now. Those are the still pictures. I'm avoiding to show you a video because of sake of time, so we'll just take still pictures of these series. So this is terional approach from the right side, nerve, optic nerve, other nerve there, chiasm is here, and this is the tumor. So you take the tumor away from the arachnoid, which you leave attached to the optic apparatus. I used the laminar terminalis approach, and we actually published this approach in skull-base surgery back in 2012. So this is a bifrontal craniotomy. I cut the most anterior part of the superior-sagittal sinus and cut the forks, and I preserved the olfactory tracts. And then I'll get this picture. Right optic nerve, left optic nerve, chiasm, optic tract, and the olfactory tracts are preserved. Nerve, chiasm, gyrus rectus, preservation of the olfactory nerve. So if you go interhemispheric subfrontal, you will dig deep into the lamina terminalis. So this is the lamina terminalis here. And you can actually pick a certain area where it is less vascular and open it. So let's see different views of lamina terminalis, how they appear in different surgeries, different patients. So you can see lamina terminalis like this. Or like this, flat. A1, A2. Or like this, bulging out. A1, optic nerve, and the lamina terminalis. Same thing here, bulging out, lamina terminalis. You can see here the carotid on the right, carotid on the left. So you can actually attack this tumor from the center. You can go to the right, you can go to the left. It's a very, very practical way of doing things. Lamina terminalis, full of the tumor. Infiltration of the optic hairs by the tumor. Like this, reddish, infiltrated, mixed with the tumor. And here, the tumor has caused atrophy of the optic chiasm and it's bulging out. A1, A2, A1, A2. Don't forget that you will face these variations of ACOM, which are so variable. And they are described beautifully in Yazarjil book. So I advise you go to Yazarjil book, the vascular one, and you'll see how many variations of ACOM are there. Then we reach to the lamina terminalis, we open it. And as you open it, you'll just get this engine fluid, engine oil like fluid. And people would say, hooray, hooray, we have done decompression. You have done nothing. This fluid will come back within 2 weeks' time. So taking the fluid out is nothing. It's part of the tumor of the surgery, but it does nothing. So here we are opening the lamina terminalis. Again, you will get this yellowish oil, engine oil like fluid. It will help facilitate doing the surgery, but it's not the surgery. People usually stop at this stage. They take biopsy and then send for radiotherapy. This is the best chance of the patient. Use it. And then we reach to the tumor, we try to dissect it. You can actually find a plane of cleavage, plane of gliosis in most of the cases. And if it is hard, you can use the ultrasonic aspirator. So different tumors, it's not one case, it's a school of thought. So you can find plane of cleavage inside the thalamus and hypothalamus. Different tumors in different patients. I thought this is better than just showing you one video. So again, you can find the plane of cleavage. Just be patient, perseverance, patience, and dedication to what you are doing. This is a child or old lady who has put their trust in you, so give them the best treatment you can first time. As I said, I don't hesitate using the ultrasonic aspirator for those cases where the tumor is really hard, very much calcified. Don't shy from using the ultrasonic aspirator. And then you can see the hypothalamus. People say, oh, you will damage the hypothalamus. If you do radical excision, you will damage the hypothalamus. No, you will damage the hypothalamus if you don't do the surgery proper, because once you send for radiotherapy has its own complication and it will cause hypothalamic damage. So you can see mammillary bodies. You can see the wall of the hypothalamus here. You can see the wall of the thalamus. And you can see the midbrain, tegmentum. You can see the helicostal membrane attached to the mesenchymal. If the stalk is tumorous, I do not hesitate in cutting it out. I don't like to leave a tumor on the stalk because it is a call for recurrence. It is already damaged. It's already infiltrated. So why should you keep it? So I don't hesitate a second before I cut it, remove it completely. Like this. If the stroke is not involved, I do everything in my experience to try to preserve it. So this is a tumor attached to the stalk. I try to dissect it gradually, slowly, take the tumor off it. This is the stalk. Then find really this plane of cleavage here, and then remove it. When you do that and you expose the mucous membrane and go beyond it, you will see the basilar artery, superior cerebellar artery, and posterior cerebral arteries, just like that. So we preserve the stalk, remove the tumor that attached here, and have this beautiful view into the posterior fossa. As I said, you can go left, you can go right, you can actually surround the tumor, don't leave one ion of the tumor there. You can see the vascular structures, as I said clearly. This is basilar artery and this is lilicust. And again, look at the olfactory tracts being preserved. If you do that, preserve the anatomical continuity of the olfactory, about 70 to 80% of patients preserve their smell. So again, here the same view for the basilar artery, the stalk that has been preserved. This is just the site where the tumor was attached to the diaphragmacelli. So clear the pituitary, clear the stalk, give the patient the best chance you can. Again, you can look right and left and center and try to make sure that you have not left a tumor there. So this is the final view. And the post-operative assessment of how much we did a gross total resection, the majority in both the adults and children. The time of life is 94 independent without impairment. These are the results, of course. Total resection achieved in 88 out of 114. How many recurrence? 11. So even when you do total resection, you may get recurrence. This is not a cause for you to not to stop yourself from doing radical resection. So total resection was done in 26. Look at the recurrence, 16 out of 26 major recurrence, while 11 out of 84 in the radical resection. I had 2 mortalities in the series. I share it with you. This is the first case of mortality. This man had surgery somewhere else outside Jordan. You can see the site of the craniotomy. They have done nothing except they have opened their skull and they punctured the cysts. So when he came to us, it was still the same. You can see the site of the craniotomy. This is after their craniotomy. I call this crime against humanity. Why are you doing this? So he came to us and we did radical resection. But sad, he showed slow deterioration and died on the 7th post-operative day, most likely because of some macrovascular damage. Mortality, case 2, a lady from Iraq with this giant tumor. We did radical excision for her. She died on the 18th postoperative day out of pulmonary embolism, not out of a neurological complication. So surgical results, as I said, 24 and 22 patients in the adult and the children improved their vision. If you believe that if you do surgery for craniopharyngioma, their endocrinological condition is going to improve, you'd be surprised. No one would show improvement in the endocrinological picture in post-operative. They remain the same. Very, 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 look at, nobody improved. None, 0. And the DI result is 0. Either it's changed or worse. So endocrinological status of the patient, it's what it was pre-operative. Did I have any morbidity? Yes. Vascular injury in 1, cranial nerves none, hydrocephalus in 2, CSF leak, and meningitis in 1. As I said, temporary endocrine worsening is 90%, and temporary DI is 100%. Histology, we published this paper in the American Journal of Pathology about the craniopharyngiomas, so on. We use every possible immunostaining markers in our department. And also we are aware of the promising options of targeted pharmacological treatment of BRAF mutant papillary craniopharyngioma. So some people are trying to use this pharmacological treatment, and it's giving some results. This is papillary craniopharyngioma negative for B catenin, and this is B catenin being positive in nuclear and cytoplasm. I'll finish with showing you some of my cases. Adults, pre and post-op, giant, and I mean giant. Again, this tumor extending from above the foramen of bone right down to the foramen magnum. Total radical excision. 45-year-old male patient from female, I think. Patient from Libya. This is also a large tumor. Male patient, yes. Before and after. Look here. Mammillary bodies are preserved. This lady from Libya with this giant tumor, she was pregnant. We did radical excision for her again. You say there is no hypothalamus. She is surviving. Her hypothalamus was pushed to the side, and we preserved it. This man came from United Arab Emirates, from Bahrain, sorry, with this giant tumor, which we excised totally and followed him up. This lady came from Bahrain with this tumor, giant tumor, retrocellular. They went in, they could not reach the tumor, but they reached the carotid and they caused an aneurysm. So if you want to do endoscopy, do it properly. In this case, it's very difficult for endoscopy to start with. So she was transferred to us, and the first thing we did is to neutralize her aneurysm with coiling, and then took her to theater and did radical excision and sent her back home. No radiotherapy. As I said, regarding obesity, if you have obesity preoperative, there will be no subsequent loss. If you develop obesity afterwards, usually there is some weight loss. So let's look at the obesity in adults. There was no new onset obesity in adults. I discovered that obesity only occurs in children. So this is the patients, no obesity, different patients, adults, no obesity, and so on and so forth. In children now, this giant of giants, so Craniopharyngiomas, Hiroshima and Nagasaki kind of atomic bomb like this. We excise totally, no radiotherapy, 12-year-old female with this giant tumor, multi-compartmental. Again, they have put a shunt. There was no need, because if you excise the tumor, there's no need for a shunt. Do not put a shunt up front. And this is the girl without a shunt, without radiotherapy, without anything. 5-year-old male patient from Iraq with this extensive tumor. He's a son of a general surgeon. We did surgery for him, and 13 days later he was skiing in Kurdistan. This boy from Syria with this extensive multi-compartmental tumor, the posterior fossa everywhere. He did radical excision for him. Again, what is the hypothalamus here? It has been preserved and it was pushed sideways by the tumor. The new onset obesity in children, 60%. So no obesity postoperative in adults, 60% of children get obese. So people are warning you, don't go for the excision because they will develop obesity. Look at this. Obesity disappears in 3 to 4 years' time. They are back to normal. So this girl, like this, postoperative, obese, and then no obesity. Same thing. Postoperative, obese, and then no obesity. From Sudan, this boy, no obesity. This girl, some obesity, and then back to normal. Same thing here. So obesity, even if it develops in children, it's temporary. So don't be afraid. Don't make people make you afraid of hypothalamic damage if you do radical excision. They will do hypothalamic damage if they do biopsy and radiotherapy. Again, here, a child with obesity, immediate post-op, and then nothing. Same thing here. Do they recur after radical excision? I'll show you. Yes. This 3-year-old female from Palestine came with this giant tumor back in 2005. I did surgery for her, radical excision, and she went back to Palestine. She had no radiotherapy, no chemotherapy, but again, she was lost for follow-up. She came back 2007 with this giant recurrence. What to do? Another surgery. One should not go for radical excision no matter what, just to present good postoperative MRI, remembering that recurrence can still occur with radical excision. So I have done radical excision, and this girl developed recurrence. Still, I'll go for surgery. I went for surgery, radical excision, and she went back home again. And this is herself without obesity, after that. A story of my life is this boy. This is the last case, whom I operated upon in the year 2000. Radical resection, no radiotherapy. Followed him over the years, 2003, 2005, 7, 2009, 12, 15, 14, 17, no recurrence, no evidence that there is any damage there. I went back to finished school and went to university, and this is him 20 years later. When I see these images, this convinced me that radical excision is the choice. So my conclusions, and I hope I did not upset you with lots of details, because I believe strongly in what I'm saying. Long, fruitful hours, dedication, perseverance, and sacrifice of one's own time to give patients the best chance first time. This is my motto. When you are operating, people around you go to sleep. You can't. You have a life of patient in your hands. Preserve it. Do the best you can. So again, I'm showing you this. I'm in the body floor of the third ventricle. But look at this. Where is the hypothalamus? It's been preserved because the tumor pushed it aside, and you could find a good plane of cleavage and you excite it like this. Where is the floor of the third ventricle? Some authors are worried about hypothalamic function when one speaks of radical excision. Little don't. If you do radical excision, they will go into hypothalamic dysfunction, and you will destroy his life and will destroy his family life. Actually, you doing this very limited resection and radiotherapy, you are damaging the patient's life and his family's life. Those people who advocate partial or biopsy, they are not worried when they speak of partial excision with the associated recurrence, multiple surgeries, radiation, and most importantly, invasion of the hypothalamus. It's their cases which will suffer, not the cases where you do radical excision. So whether it's microsurgery or endoscopy, the aim is radical resection. And you decide whether you are going for partial radical excision during surgery. I go in and my mind says, I am going for radical excision. Then I go in. If I can do it, I do it. If not, I stop. But I go with the state of mind, I want to remove it all. While those people who said preoperatively, upfront, before this starts, oh, we will do partial resection and then give radiotherapy. This is wrong. This is crime against humanity. I am against the planned upfront limited resection and radiotherapy. I'm against other adjuvant therapies like Omeyer, Zalbar, and Schultz. So you start the operation. If you tell yourself, I'm going for biopsy and partial resection, you are a failure. Tell yourself, I'm going for radical excision. So people still saying, result of radical, and they teach this to their juniors. Results of radical excision is not superior to partial excision and radiotherapy. They convince their juniors that, okay, why should you do radical excision? Well, if you do partial excision with the therapy, it's just the same. This is wrong. This is not built on anything in the literature except very few cases. So this is sending the wrong message to the young neurosurgeon. They translate this. If my boss is doing this partial resection or biopsy and radiotherapy, I should be doing the same, which is do the minimum and send for radiotherapy. This is wrong. Then I'm showing you this slide. I'm not showing myself as the ultimate knowledgeable man of management of craniopharyngiomas. I'm just a man who believes in what he's doing, and I hope you will subscribe to this theory. Thank you very much.
Okay, thank you. Excellent, Dr. Sbeih. And let me see, Ben, are you able to moderate, or you want me to moderate? We have an all-star cast here in the panel. Ahmad Prasad from Afghanistan, Takashi Hashad Parek, Martin Woodville from Dubai. I'm going to ask Takashi, can you moderate the questions, Takashi, please?
Yeah, thank you, Dr. Ibrahim. So good. result of the very difficult cases of craniopharyngioma. And microsurgical anatomy is very defined, well-defined microsurgical anatomy. So a very informative lecture. And thank you for showing many Japanese doctors. They are very excellent doctors in Japan. So you learned a lot from also Japanese big guys, big neurosurgeons. I would like to ask you, because Ommaya tube is not effective for cystic craniopharyngioma. Total removal is very important, but post-operative cognitive dysfunction is a very problem for children's craniopharyngioma surgery. After the patient, is there any case of the patient needs a VP shunt after hydrocephalus after surgery? I experienced a case. How to manage for long-term hydrocephalus management?
The last question about the hydrocephalus. I think the shunt is very abused in the whole world. People with limited experience, they just put shunt for anything. For a colloid cyst, I've seen colloid cysts with bilateral shunts. For goodness sake, when are we going to stop this? Because if you remove the colloid cyst, there is no need for a shunt. There's no need for a shunt if you remove the craniopharyngiomas and so on. So I'm totally against a shunt. And on all my patients in whom I removed the tumor, there was not a single case of hydrocephalus afterwards. But those who had partial resection, they had hydrocephalus. The other question about the cystic ones, you still can remove, you will still find a wall, and then you can remove it. Now, cognitive functions in children, if you damage the hypothalamus, it will occur. But if you find a good plane of cleavage, they will not.
Thank you. Thank you.
Thank you, Professor Ibrahim. Thank you. Very, very important and very impressive experience. I see the video is very impressive. So big tumors and the removed result was so good. Thank you.
Thank you very much.
Okay, Ben's at the airport.
Yes.
Oh, you made it. Thank you for coming. Thank you.
Okay. Thank you.
Can I ask Dr. Sbeih?
Yeah, go ahead,
Yes.
Martin.
Yeah,
Introduce yourself,
well,
please.
thank you
please.
very much for this excellent message and actually underpinning it with personal experience and I actually prefer the pictures you give instead of a video where we just sort of see one case. So that's very, very valuable and you kind of made an atlas there for all the different situations. Now, one of the reasons why perhaps surgeons falsely took a conservative attitude was because during these sections, as we all know, you can run into trouble. And can you please elaborate a little bit? Maybe you have some technical tricks. I see one remark you made about the ultrasonic aspirator in calcified tumors, and it's actually my personal experience that exactly the calcified will be most useful to, you know, kind of morcellate the whole thing and make it soft is often my Q-size or whatever ultrasonic aspirator is not working. So then I have to use the knife and the scissors and piece by piece. And as you say, operations become very long and it's a game of patience. But please elaborate a little bit on the technical side of things, because you eventually have to deliver the whole tumor in the approach you favor through this relatively narrow window of the lamina terminalis. Of course, as you get more tumor out, you get more space, but still there are areas which you cannot properly see and so on. Please elaborate on that and some tricks, maybe some lessons you've learned.
I don't hesitate using the ultrasonic aspirator in full power. So not 10%, not 50%, I go to 100%. And I just keep the ultrasonic aspirator on it. For a minute or two, nothing is happening. But if you just keep it there, it will vulgate. Piece by piece, slowly, it will vulgate. Now, I don't go for those calcified tumors where they are going into the wall of the carotid or the wall of the basilar. You can tell that these are inoperable. You have to stop there. But I don't, as I said, it is state of mind. My state of mind before doing surgery, I am going to remove the whole tumor. Sure. I go there. If I have to stop, I stop. But I don't decide this preoperative. So I'm against those who say, well, craniopharyngiomas, whether you do it in a gross total resection or biopsy, this is not.
Absolutely agree with that. And the similar attitude needs to be applied to acoustic neuromas, where similar
Absolutely.
discussions sometimes.
Especially in the age of gamma knife, which is also abused. People are going for debulking of the vestibular schwannoma and then send it for gamma.
Yes,
What
when
is
you
this?
actually have easier planes. But again, the very dense tumors, very fibrous tumors, and it has been, I mean, obviously I don't have so many cases like you, but it has been my experience that sometimes on the MRI, they look hypotense and it looks like, okay, this is going to be soft, but in fact, actually it turns out to be very dense and fibrous tissue. So as long as you're moving in the big ones into the right direction where there's not going to be a major vessel, so you can use the ultrasound. So I am very grateful from you to hear that I just hold it there for 2 minutes and eventually it will win over the calcified bit. Thank you for that tip. Thank you.
Okay, more questions, comments?
Thank you, Professor.
Go ahead, Saeed. You want to ask a question? How you doing, Saeed?
Fine, and you? Thank you very much, Professor Sbeih. It's a great pleasure to have you at this webinar. It's a great job, and I appreciate what you do. I'm like, as you told you, I'm for a radical excision. And to give the chance to patients, because radiotherapy is not a solution. Of course, so we can in some case stop because there are calcification on carotid artery, basal artery, but we go, as you told, for radical excision. That before surgery, we go for radical excision. So I'm in the same line of you, radical excision first. Thank you very much. It's a pleasure to see you.
John, I can see one of our medical students from Jordan by the name of Zahra Adam. Zahra, do you want to say anything?
No, sir. Thank you so much.
Very, very good. I think we have a question from Ahmad Pirzad, an Afghanistani neurosurgeon. Ahmad, are you there?
Yes. Assalamu alaikum, Professor John. Thank you very much. And Professor Sbeih, assalamu alaikum. Congratulations for your presentation. And it was great. And it was also have a educational purpose. And we learned a lot from you. Just I like to say thank you and also congratulations, and it was great. Thank you.
Thank you.
I'm from Afghanistan.
Thank you.
Thank you for coming. Okay. By the way, Saeed is from the Reunion Island off the coast of Africa. Any more questions, comments before we move on to the next?
Hi, John.
Go ahead.
Hi, John.
Hi,
I'm doing fine. Hello, Professor Ibrahim.
Hello.
This is Dr. Harshit Parekh from Mumbai, India. Excellent lecture and brilliant demonstration of the total excision of your craniopharyngioma. And you have a large series. I've been instrumental in treating these cases at large, and recently I've seen others being operating and demonstrating. And I totally agree with you. One should try to go for a radical excision as far as possible. There is no role of cyst aspiration and leaving behind for a radiotherapy. And as I agree, the radiotherapy is not the alternative and just after a biopsy. But at times it is very difficult to achieve a radical excision because these tumors are adherent to many times vessels. You were brilliant to remove separate from the hypothalamus, and many times I have found it is difficult to separate. And even the optic chiasma. The problem comes with the calcification. Many a times the calcification is so stuck to the vessels, very difficult to remove. So we have to be happy with the subtotal excision or a partial excision at that time. I agree, the radiotherapy doesn't work and the recurrence rate is very high. Even in most of the series, it is more than 15 to 20%. It's excellent presentation. Your message is very clear and I take that message very clearly. Yes, we also try to achieve the radical excision, but many a times it's difficult. It's difficult.
I agree with you. One has not to be courageous on the expense of the patient's life and function.
Yeah.
So if I find that I really can't after trying to excise it because it is calcified, because it's stuck to the cyclus, I stop. There's no point in proceeding with something that is going to damage the patient. I accept defeat in this case, but having tried my best to take it out. And remembering that radiotherapy for kids, it is the cognitive function, it is damaging their preschool life. So people are forgetting this. The majority of patients with craniopharyngiomas are children. To give radiotherapy for children is not.
And when you are trying to attempt radical excisions, the post-operative morbidity is quite high. There is a permanent DI, plus many a times we face the problem of convulsions many a times post-operatively. And the chemical meningitis, this machinery oil fluid, which when spills on the CSF, it causes. So there are issues of that. And I still feel after so many years, the craniopharyngioma, we haven't got achievement like what we have got achievement for the meningiomas in most of the times. So one has to be balanced in removing when you are achieving to remove, when not to venture into further and harm the patient.
I'm not against partial resection. I'm against people deciding beforehand, upfront, before going to surgery, I am going to be very selective, removing part of the tumor and send for radiotherapy. I'm against this. I'm with the idea that one should go with the idea of removing the tumor as a whole, but one should be careful to stop when he finds no primary cleavage or it is calcified.
Okay, very good. Thank you for the questions.
Hello, this thing, you were superb in your and wonderfully demonstrated.
Okay, thank you. Any more questions or comments? We're getting a lot of feedback, Dr. Sbeih. That's great.
Yeah,
I just want. Go ahead, Martin.
I just want to make one comment. You know, I think Professor Ibrahim, he said quite correctly that patience is really it's very important. I mean, when you face these very dense tumors, and so you just gradually work away through a narrow space, and eventually, so then the question also becomes, I mean, I don't pride myself in doing quick surgeries, especially things like that. So I never hurry up. So I just forget about the people around me, anesthesia or all the rest of the people, and I just keep working away on it, which makes these surgeries a little bit long ones, especially these large ones. So then I want to ask you, what has been your experience? Obviously, you've done a lot, so you become a little bit faster. It depends on the case. But when you have these giant ones, what would be your average estimated OT time for those?
Something like 12 hours.
Yeah.
12 hours minimum.
Yeah, minimum. They are in that category, and I think for surgeons who don't like that, they're skilled microvascular surgeons, whatever, they do aneurysms, they finish in 3-4 hours, and they don't have the time. Well, if they don't have the time, they shouldn't start doing it.
Absolutely right. Thank you.
Yeah.
Okay, very good.
Thank you very much.
Professor,
and again, excellent
Sbeih,
presentation. I've never seen anything quite like it. Very, very good.
Yeah, okay. Saeed, did you have to go ahead, Saeed?
Yes. I want just to talk about an important point. That's the role of the endocrinologist, because intensive care, they have not experience with these patients. So we need an endocrinologist who can give adequate treatment to this patient in the immediate operative period. So we had some trouble with in the research in the Department of Anesthesia, but now we have endocrinologue that take place in the postoperative immediate postoperative surgery, and they follow the patient all the day.
Thank you, Said, for bringing this, because I think a good endocrinologist is as important as a good neurosurgeon. You don't have a good endocrinologist in your department, you'll face troubles. Endocrinologist is the one who's going to manage these patients postoperatively, and we know that 90% of them will get the sodium high as 170, 115, as low as down. So you need a good endocrinologist with you. It is not one person show, it is a teamwork. The anesthetist, the neurosurgeon, the scrub nurse, the endocrinologist, the radiologist, all will form one team for the sake of this patient with this difficult tumor.
Okay, very good. We're running a little late, but we have Dr. Burhani. Do you have a quick question for Dr. Sbeih?
Thank you very much. Great lecture. Dr. Sbeih, just about the technique. If you try to separate the olfactorious, but sometimes it is part of the brain. How do you do that? Offer that one, or just to try to the end to dissect that one? Thank you.
The question is about the preservation of the olfactory tract. I always preserve the olfaction, because I believe olfaction is a very good sense not to be missed. I'd like to smell my food, I'd like to smell my perfume, so I think of the patient would like to spare their smell. But as I said, when you preserve the functional anatomical continuity of the tract, doesn't mean that you have preserved olfaction. 80% they will, 20% you've lost it. But if I find that I can do the surgery with the preservation, I always do that.
Okay, very good. Excellent, Dr. Sbeih. A lot of interest, but unfortunately we have to move on. So thank you very much. And Dr. Ben, are you there? Do you want to introduce the next speaker, or you want me to? You may be indisposed at the airport. If so, let me introduce the speaker. The next speaker is a doctor from Beijing Tiatan Hospital, Capital Medical University in Beijing. Hi, Zhu. I hope I'm pronouncing that correctly. We welcome you, and he's going to talk about the roles of L1 CAM in Alzheimer's disease and spinal cord injury. So welcome, Hi. It's all yours.
Okay, thank you, John. And can you see my slides, and you can hear me, right?
Not yet, not yet. Okay, full size presentation mode.
Is that okay? Is that okay?
No, you got to put it on presentation mode. Yeah. There you go. Perfect. Okay.
Okay, you can see my slides, right?
Yes, perfect.
Okay. Thank you, John. And also, I want to say hi to all the audiences here, and especially Professor Xu. And it's completely darkness outside in Beijing, but thank you for having me, and I'm very, very grateful to be here. And my today's topic, I just want to say I'm impressed by the Professor Ibrahim, and also his life-saving surgeries he showed. And now I want to present my topic is establishing an anti-infective system for the extended endoscopic transnasal surgery, because the transnasal surgery is now. Yeah, it's not Parkinson or spinal cord injury. It's about the endoscopy.
I apologize for that.
Okay, it's fine. And also, as you know, the endoscopy is another alternative treatment for craniopharyngioma and meningioma in the skull base. And I want to say is infective, intracranial infective after surgery could be sometimes is life-threatening, but most of the cases is prolongs the length of stay, and also patients got more time to have antibiotics. And this is a very big problem for endoscopic surgery, and also sometimes it's optical for endoscopic surgery to go further. And today my topic is why we use establishing, because this is a project we are ongoing now, because it's far from success, it's far from the establishment. And this is our try to decrease the incidence of the infective after surgery. So I shall start with a self-introduction in case you want to know. I am approaching 36, and I'm graduated in 2015 at Capital Medical University. At that time, I spent 1 year in the Karolinska Institute, Stockholm. Very fond memories, and to have a doctoral training program. And nowadays, I'm a specialist in neurosurgery, and my personal interest in recent 2 or 3 years is one is the preventive protocol for post-operative CSF linkage and intracranial infection after transnasal surgery, because the connection of the CSF linkage and intracranial infection is very, very close. We can't get rid of each one we talk another one to not talk about the other. This is part of the work is we do in the clinical practice. And another one is the intracranial pressure and visual pathway. And in recent about 3 to 4 years, and we have clinical practice in this one. And also we have built a rodent intracranial pressure model in the rodent model. I don't want to expand this much more. And if we have chance, I'm very happy to do in the future or sometime. So this is my contents today, and the CSF linkage is an endoscopic transinfective system, and also what to do to prevent post-operative CSF linkage, and also intraoperatively we have a hierarchical skull base reconstruction protocol, and post-operatively some experts want to say the lumbar drainage, is that helpful? We don't know yet, but I have discussed this question here, and I just leave a question mark here. And also, I want to say, what else can we do before the surgery? And this is not a correct sequence, because we always do all the surgery and then intraoperatively and postoperatively. Why I put this, what we can do before the surgery in the last part, because this part is less data supported. And this is one we have funded to go further some project I will introduce very briefly. And so this we can see this is a perioperative system for anti-infectives. So then I give a little bit of words about the summary of my presentation. I don't know whether all the audiences noticed, audiences get familiar with the CSF link in the endoscopic transnasal surgery. This is a very common one after resection of pituitary adenoma. And you can see there are diaphragmatic Sbeih, very weak point, and there is a whipping link from the CSF. And we have just used the collagen sponge to fill the dead space, and after filling the cavity, and we can see there is not too much link from the weak point of the Sbeih, but we can still see the arachnoid, and there is a whipping link. In this way, we will use a fat pad. This is the old traditional way we repair the link. We have a fat in the and also there is an artificial dural. We are not using it very often now, and also they give an additional support. And then there is maybe a nasoseptal flap. This is another full-size one, but it can somehow give some blood supply for the healing of the materials. And I want to say this one is after a resecting of the craniopharyngioma. I want to say this is a multi-layer reconstruction, not one single fat, because the neural defect is large, and we have the fat pad, we have the full size of the nasal septal flap to give the blood supply. And this one, we finished the multi-layer reconstruction, and this is now the way we construct the skull base nowadays, but in the last 5 or 10 years, we do this in this way. So the last 2 videos show that the link is different. It's different in all the surgeries. So this is an article from the 2007. This research team graded the cerebral fluid link grading system to 0 to 3. And 0 would be absence of the CSF link, and the 3 is the large CSF fluid link, typically created as a craniopharyngiomas and meningioma patients after endoscopic surgery. So we have different graded system, and in this way, we should repair the skull base in different way. We can't use the same strategy for grade 0 and grade 3 links. This is a topic as they discuss, and if they have no cerebral link, cerebral spinal fluid link, and they have the collagen sponge only. And also grade 1, grade 2, grade 3 more complicated when the graded elevated. And the grade 3, we noticed that in the 2007, they use a lumbar cerebral fluid division for 48 hours. This topic I will expand later, and this is, I just mentioned it here. So this is 2007. Actually, in 2006, there is a milestone in the endoscopic surgery, especially for the large dural deficit repair. This is a flap, vascular pedicle nasal septal flap, and we can harvest the flap from the nasal septal, mid septal, and use this flap to cover the the cavity of the surgery, and also to the entire skull base. This is a very nice nasal septal flap, and also we used it all the way in this recently repaired the skull base large dural defect. This is a completed milestone. Okay. And this is reduced. In the paper, they call this, after using this flap, they reduce post-operative CSF link incidence from the maybe 20 to 30% to less than 10%. This is a completed milestone in the endoscopic surgery. And also after this nasal septal pedicle flap, and in 2018, the same research team, they evaluated the graded repair system. They also graded the link from the 0 to 3 is not too much change, but actually, I noticed there is 2 very important change. If there is absence of the CSF link, but if patients have the intracellular graft, if the large cellular dead space emerged. This is way we use now because patients may not have the obvious CSF link, but if the patients have a large tumor, and we will use the fat graft if a large cellular dead space emerged. And then the grade 3 link, they deleted the use of the lumbar drainage in the guideline, and they use the nasal septal pedicle flap layer over the defect. So the lumbar drainage in this way is not that important, but sometimes we also use it. In 551 operations, they have grade 0% for grade 0. Of course, it's very low, and the grade 3 is 4.8. It's relatively low, but not low enough. And also post-operative intracranial infection is a grade 3 is a 4.8%. This proved to be that if patients have post-operative CSF links, they have a very high incidence of intracranial infection. Sometimes this intracranial infection can be cured by antibiotics, but sometimes we have met a lot of cases with the burst infection, intracranial infection, especially in young ladies, and they have a very quick deterioration after surgery, even life-threatening changes. So we can't ignore a single one with the intracranial infection. So this is how we repair the intraoperative CSF link now, and this is a case of the adenoma, pituitary adenoma with apoplectic, and this is a relatively large one. And after resection of the tumor, I think it's good, and also we can see there is a very point of the diaphragmatic Sbeih, and there is a very large dead space. So we give a dead space, and also this is a flap. It's not very full size of the flap. This one is completely unusual. So in this way, the patient goes well, and also there is no post-operative CSF link after surgery. So this one is the grade 0 link. We can't see, we didn't see any obvious link after in the surgery, but we use skull-based reconstruction. And the second case is there is this is a large tumor basically in the cavernous sinuses, and after surgery, actually, I think in recent 2 to 3 years, the most significant progress in our center is we started to use suture in the under endoscopy. Sometimes we think suture is time consuming, is not impossible through the very narrow nasal cavity, but we keep practicing. In the recent 2 years, I think we have mature suture techniques, and the significantly decrease of the post-operative link proves that the suture may be the next step. We solely reconstruct the skull base. So this is one of the cases of the suture. We can see this very weak and weakening point of the weakening of the CSF leak. We have the sponge to fulfill the cavity, and then we have suture, continuous suture for 2 stitches to have this diaphragmatic Sbeih to the skull base dural. And after 2 stitches, I think this is a solid repair, and we also use the multi-layer, cannot be ignored. We use the fat pad, and there would be a very full size of the flap, full size of the nasal septal flap to give a good blood supply. So this patient goes well after surgery. There is no chance to be post-operative CSF link. So this one is a recurrence pituitary adenoma, and in the surgery is very thin of the diaphragmatic Sbeih, and there is no shrink at all, and we can see there is a link, and we just use the continuous suture. It's not too much stitches, and very confident repair about this kind of continuous suture. And we also use flap. We also use fascia and also the fat. Because this is a recurrence one, we cannot harvest a very satisfying nasal septal flap. But this kind of suture gave us confidence to sleep well in the night, because we don't worry about patients get any chance to be a post-operative CSF link. Just like a craniotomy. We sutured craniotomy all the way, but we recently practiced the suture in the endoscopy, but not on the patients directly. We do it in the lab and practice our skills very fluently, and then we go to the patients. And this one is a very large one, and we published in the 2019. Because after resection of the mandibular large dural defect, and what we use is we harvest the fascia from the thigh, and also we have a continuous suture to repair the dural defect. Then we have a fat pad and also a full size of the nasal septal flap. This is how we suture. We have artificial membrane in the inner side, and we have fat here. This is very early one, about 2018 or 2019. At that time, we take about at least 1 hour to more than 1 hour in the beginning to have this kind of repair. And also they have cooperated by the assistants, and this is very demanding in the first. and we can suture in the clockwise or in counterclockwise. It's also okay. And how to knock it is also a very difficult techniques in the beginning, but now we are very skillful about this. So this is a continuous suture, and in this way we can somehow some way watertight repair about the dural defect, just like we always do in the craniotomy. I don't want to show all the procedures because it's about 4 minutes, and we just give this kind of continuous suture, 1 stages by stages. It's not easy at the beginning, but nowadays we suture this kind of defect for about 45 to 50 minutes. So we can finish this. We can always have this kind of suture in all the cases of craniopharyngiomas and also the meningioma patients. Anyway, I just move it faster. This is a whole procedure of the suture, and also we put it the last stitch. That's the last stitches, and also we just cut it, knot it, and cut it. This is how it looks after we repair, and also we have a multi-layers. We have a fat pad, and also we have glues to enhance this kind of repair strategy. I think this is the last one. We just have a knock with the line here. This is how we repair the link, and also we have glues to enhance. And then we have a fat pad, and also there is a full-size flap to give the blood supply. So in this way, in recent 2 years, I can't remember single patients to have a post-operative CSF link. We have data later published, and also this is a very good way to the grade 3 links after tumor removal, while endoscopic endonasal approaches. But unfortunately, in the beginning of the 2 year or 3 years, there is one case with failure to repair and will have a post-operative CSF link. These are meningioma patients. We have the endoscopic surgery and the tumor resect well, but patients have post-operative CSF link. So the reason why we repaired failure is that one failure is that there is a flap, but the flap looks not good. The blood supply is not good as the other one. It's a little bit not the signal here is not right, and also there is a dead space between that and have a post-operative CSF link, and we go to the second surgery, and we found there is 2 stitches of the CSF link from the 2 stitches of the suture, and we have another suture during the second surgery, and patients goes well after second surgery. So this one is, I think, is a perfect flap. First, the length of the flap is enough to cover the skull base, and also there is no dead space in the flap and the cap. So this one, if the patients have this one kind of nasoseptal flap, we don't worry about the post-operative CSF link. Additional with the repair and the suture. So we are not the only team to have the suture. Basically, I think in the East Asia, in Japan, South Korea, and they advocated suture just like us. This is a 2010 team. They have 3 types of dural suturing for closure of the center endoscopic transnasal surgery. And also using this kind of 3 types of dural suturing, they decrease the post-operative CSF link for 3.9%. And I think in our center, I think our data is a little bit better than this. And I can't say it clearly because we just do the calculation here. And in my opinion, in my memory, I can't remember one case in recent 2 years they have post-operative CSF link. But this one is dependent on the patient's nutrition status, because if they have the bad nutrition status, they will have a bad healing procedure. procedure. So patients may have about a couple of years ago, there's a patient very thin female, and they have very bad nutrition status after surgery, and she has the postoperative sepsis link, and we go to the second surgery to suture again with good recovery after the second surgery. So this is the type 1 suture link, and also there is typical what we saw in the resection of pituitary adenoma, and their triangle suture of the dura. In this way, the suture just gives the support of the fat to avoid the remove of the fat. And the type 2 is they have a very opening, large dura, and they can have the shoelace, just like the shoelace suture. And there is a fat inside and shoelace suture outside. There is another fat pad in the after they suture the case, and there is a buttress to give a rigid support for the reconstruction. And the type 3 is just like this. After resection of the craniopharyngioma and also resection of the meningioma, there is a large deficit. It's completely impossible to give shoelace suture, and they have a fascia and continuous suture of the dura, and then there is a fat pad and a rigid buttress. So in this way, they decrease also intraoperative cells link, postoperative cells link. I think suture is a very good way to avoid the postoperative cells link. So this is Professor Kim from the South Asia. I met him. I think in the 2018. He came to China for the World Meningioma Congress, and he is very dedicated to invite some surgical instruments to give this kind of suture more easily and faster. And this is a picture. He gives a clipping instruction. Instruments to give this kind of repair more easily. But I think this is a very idealistic. In most of the cases, we can't see this kind of defect like this way to clipping in this way. But I think this is a very good direction for the further research, and we have much better instruments, and we can do it faster and safer. So this is what I think about the suture. I think it's a new direction, but it's not. I think it's not recommended by all the neurosurgeons. But in our way, upon our practice, I think this is a very good one. But need practice, of course. So the question is, we decrease the postoperative cells ratio to a very low point, but how about the infection? We notice that in our data, we have 1 patient in 36 of the suture patients have postoperative link, and 9 patients of the 43 patients before we suture. But how about the infection? There is no significant difference. Because we suture the postoperative cell link is decreased significantly, but we can't decrease the infection after surgery. So the reason why the intracranial infection is not decreased, I think is one reason for the surgical factor, because after we suture, we have a very longer time for reconstruction duration, and the intracranial spaces is exposed to the environment for the operation room environment for a longer time. So this is one I think is the kind of increase risk of the postoperative infection after surgery. We use less time to do the reconstruction, and we have new data whether we can have this kind of lower the incidence of the intracranial infection. This is how we suture in several cases, and this is craniopharyngeal for resection. There is a very good flap we saw before, and this patient goes well after surgery. And also, I want to talk a few words about the lumbar drainage helps. Whether it helps is debate, and someone supports this kind of lumbar drainage is because they're reducing the stress on the repair, allows the initial healing to occur under decreased tension and lower the chance of the persistent fistula. It's true. It helps in some degree, but not all the cases. So for the patients who protest about this kind of manipulation is because after the drainage, the patient may have spinal headache, radiculopathy, and also there is a very important issue about over drainage is very dangerous in some way, and also in this decreased patient's mobilization is very important, I think, especially strictly lying on bed for 45 days and pneumonia or thrombosis, I think is it's a risk we can't ignore. So this is a completely lumbar drainage, I think, is Andrew and Damon relationship, but just there is still debate and there is no consensus at all. But how we want to I want to explain this is there is a very good article in the Pittsburgh in the Pittsburgh School of Medicine. They have a prospective randomized control trial, and they have very good results. And with lumbar drainage, there is only 8.2% of patients of 85 patients have a postoperative sepsis link. And there is no lumbar drainage, there is 18 patients, it's over 20%. I think this, in nowadays, it's an article in 2018 or 19 or something. But I think the 20% of the postoperative sepsis link is unacceptable in recent days. But for the experiment, they think the lumbar drainage is useful. But for the meningitis or intracranial infection, no help for the lumbar drainage. So this is a link, but it's a not good way to use it to treat no useful lumbar drainage for infection. So they're also talking about as endoscopic skull-based surgery techniques improve and CSF link raise lower even further, and the lumbar drainage may no longer become as significant. And also another one is the different closure techniques, especially for limited defects, may produce different results and therefore may not have the same results with LD. So in our center, I think in one whole year, we can't use lumbar drainage for less than 5 cases because we have a good repair of good reconstruction of the surgical defect. And lumbar drainage making no sense because infection is no use for lumbar drainage. So I think less than 5 months about the repair, or patients have a very bad nutrition status, sometimes we use lumbar drainage. Sometimes it helps. And I also have a very bad memory about the lumbar drainage. There's typical cases of craniopharyngiomas. The patients have a large calcification in the tumor, and we have the endoscopic surgery. It's a very good approach. And in the postoperative day 1, I think the tumor resected is good and the patient goes well. But at that time, we use a lumbar drainage. We don't suture at that time. We just give the lumbar. We just give the multi-layer reconstruction of the tumor skull base, and we do the lumbar drainage in the first day after surgery. But we wanna at that time we kept the lumbar drainage for 4 to 5 days, and the day 4 there may be some drainage, over drainage in the after surgery, and also there is unreliable skull-based reconstruction. There is a link point, and there is tensive pneumocephalus happen. The patients have a decreased consciousness, and we have a merchantity, and immediately we give a catheter in the ventricle. but it not help a lot because this is not fluid, not hydrocephalus, but the pneumocephalus. So say we gave a second surgery immediately to have a second repair, reconstruct the skull base. The patients after that, patients endures a fungi infection of the intracranial infection. It's a very difficult one, but the patients luckily go through all these difficulties. And before the discharge, I think it's about nearly 1 month after the first surgery, and the patients have a sign of the hydrocephalus, but she have no symptoms about this kind of hydrocephalus, and we just keep it watching. So the patient goes well now, and unfortunately, she has a recurrence tumor last year, and we have a craniotomy, second craniotomy surgery for these patients, and goes well in the second surgery. So this is a lumbar drainage helps. I leave the question mark here, and this I think is a completely debate and no consensus as well. In our way, we can't use lumbar drainage anymore if we have the suture, better suture, and also a very solid reconstruction. So can we do something before the surgery? This is very less data supported, but we are doing now. We depend on the CSF culture. It's a gold standard now. But positive rate of the culture is 30 to 40%. Actually, we have 7 patients over in our that study. We show in the suture study, we have 7 patients in all, about 80 patients. 7 patients have intracranial infection, but this is proved by the CSF culture. So considering about the positive rate of 30 to 40%, I think nearly half of the patients have the symptom of the intracranial infection. And also the culture is very time consuming. It's about 4 to 5 days to give a culture results. At that time, we can't wait. The patients have fever, have the signs of the intracranial infection. We can't wait 4 to 5 days to give the antibiotics. So we gave a very strong antibiotics for the patients, and sometimes it's unnecessary. So we start to think how we can do it before the surgery, or we have better than the positive than the control or culture than the culture after surgery. So we notice there is MNGS, next generation sequencing with a high sensitivity and specificity for the microorganism in the CSF specimens. This is a consensus of the Chinese use of this kind of NGS on the intracranial infection. And also there is a lot of articles describing the using of the next generation sequencing on the central nervous system infection. Can we do something on this? This is what we want to do. And the microorganism in the nasal cavity, is there some kind of relationship between the nasal cavity and the intracranial infection? We have evidence. The actually the previous research we continue now is there is 3 patients. All patients have extended transnasal surgery, and also we have a nasal swab. Before the surgery, they have some kind of bacteria, and after surgery, these 3 patients have an intracranial fraction, intracranial infection. And then we have CSF NGS, MNGS, and proved to be that the intracranial bacteria causing the intracranial infection is the same bacteria we detected in the nasal swab. These 3 patients, we have the positive reds, and also I think this is one of the evidence, not very strong one, but I think it's a very good try to go further. And we first want to say the microorganism in the nasal cavity have relationship with the intracranial infection. Then if we're dealing with the microorganism in the nasal cavity before the surgery, whether we can decrease the intracranial infection. We have the evidence too, and the patient 1 and patient 2, they have the post-operative day 1 CSF NGS, and all the patients have the bacteria in the NGS. We don't know these patients will get intracranial infection because this is a project we started just the last week. This patient is underwent the surgery last week, and we just follow these patients maybe in the tomorrow or the day after tomorrow. We give them the second CSF NGS to see whether this kind of bacteria grow in the CSF. This kind of bacteria is always the common bacteria in the nasal cavity. So this is evidence too, and we wanna go further to see whether the relationship is real. So this is what very briefly introduce the procedure of this kind of research. And we just recruited patients with estimated grade 3 links like craniopharyngiomas, meningioma, or the giant pituitary adenoma. And we gave them the nasal swab MNGS before the surgery. And then we have nasal flush and oral antibiotics for 2 weeks. And then after patients come to the we can see whether the effectiveness of the nasal management before the surgery can have some effect on the because the nasal flush is a very common use for the rhinitis in the other departments. So whether we can see using the MNGS, we can do something about the nasal flush effectiveness. So we gave them the antinasal transnasal surgery, and also post-operative day 1 we have CSF MNGS. If have the positive results, we give them antibiotics for the certain biotics. If the negative, we just observation. And the day post-operative, day 4 to day 5, we gave a CSF NGS again to see whether we have a very good effectiveness of our treatment, or we just ensure that they don't have the sign of the intracranial infection. They can discharge from the hospital very safely. And this couple of questions we want to ensure is that one is the relationship between the nasal environment and the intracranial infection. And second one is the efficacy of the nasal management before the endoscopic transnasal surgery. Can we lower the incidence of the infection? And then the early alert of the intracranial infection, because first day we gave the MNGS, we can see whether they have the bacteria in the CSF. We can start the sensitive treatment immediately, not to worry about the 4 to 5 days after they have positive culture results. And for patients, they have antibiotic burden reduction. Before, if we want to make sure the intracranial infection is under control, we always use 2 antibiotics. But if we have sensitive results, and we can only use 1 or weaker antibiotics for reduce the antibiotic burden for the patients. And also, we want to see whether we use this kind of nasal swab and oral antibiotics before the surgery. Can we shorten the length of the stay for the patients and also lower the cost for the patients? This is another topic for the economy problems in the department, and I want to see it together. So here is my summary, and I think in this 30 minutes you can understand what I'm talking about. And nasal flush and management, this is the right sequence. And before the surgery, we have the nasal flush and the management. Can we make a difference about the infection of the intracranial infection after surgery? And also, I think I want to emphasize that key element of this system is anti-infective system is a solid skull-based reconstruction during the surgery. If you don't do the solid skull-based reconstruction, the nasal flush, the lumbar drain usually don't help. So I think the nasal skull-based reconstruction is the most important one for the system. And also lumbar drainage after surgery, I only can say sometimes it helps, but not very reliable. As we talk about this, the solid, if you don't have the solid skull-based reconstruction, you can't depend only on the lumbar drainage after surgery. Sometimes it is failure and it's a disaster for the patients. And also, we want to build the system. I think the systemic protocols are very necessary. We put everything on the paper. Patients follow a certain protocol. I think this is a very good system for patients and better care for the patients. So this is how we started. We always, in Chinese, we always want to make a very difference. We want to be someone in the neurosurgery, but sometimes big difference comes from the small steps in the beginning. So we are very and started from the beginning. So we have books, we have foreign books, and we also have our own books to give us guidance. And also we have a very good team. We have a team leader and also mentor. And we have companions and friends who are also interested in these questions. And I think this is a good way to practice. And also I want to say to suture, to have this technique of suture, I think this is not a very difficult one because it's time consuming. We just use 5 years, even more, to have a very better skill of the suture. But building a culture, I think, is more difficult. Every doctor come in the team involved in the study, so we do the same protocol, we do in the same standard. So I think this is more difficult, but it's very time consuming with a very long time to build a culture. And also, this is a Chinese picture. It's told the patients trust the doctor. I think the patient's trust and confidence about us is at last but not least is very, very, very important. So we have patients, we should do the better care to fulfill their wish and also fulfill their confidence. So this is all about this, and also is so grateful to be here. And thank you for your attention. This is my email address. And this is my telephone number, both basically for the Chinese audiences. So you can contact me as you wish, and you are more than welcome. So thank you. Thank you.
Okay, thank you very much. Excellent. I'll open up the questions in a second. Ben, are you there? I don't know if he can moderate. If not, I'm sure we have a lot of possibilities. Well, I'll just moderate. We have an all-star cast here. Saeed Taha, Okenzi Kanu from Nigeria, Martin from Mumbai, Harshad Parekh from India, Dr. Burhani, I believe he's from India, Ahmad Prasad from Afghanistan, Ibrahim, who gave the excellent lecture first, and Takashi Khan. So I don't think we're going to have a shortage of questions. Okay, so let's open the gate. Okay, go ahead, Dr. Sbeih.
Thank you very much for a very interesting presentation. And I was glad that you had some training in Karolinska Institute when I spent 6 months there for the Gamma Knife. It's a very nice place. My question is a little bit strange. During the epidemic of Corona, people used to take swabs through the sticks in the nose. And there were reported cases of CSF leak after this procedure. Are you still doing the swabs through the nose or through the throat?
Actually, from the nose. It's from the nasal swab. It's basically from the nose because it's more complicated for the oral cavity. The organism may be more complicated. We just focus on the nasal cavity, and but there is some link in the cavity because it's all going through. But we just focus on the nasal cavity first.
I'm asking this because there have been few reported cases of CSF leak after nasal swab.
Oh yes, yeah. No, I think we can't go deeper enough to cause the CSF leak. I mean, it's just in the we can't go too deep to cause the CSF leak. Just in the frontier part of the cavity. It's not that deep. Yeah.
Okay, next question. Martin, do you have any comments?
Yes, can I just ask a technical question, which of course that this suture, even if it doesn't really do a watertight, it just keeps the whole grafting system in place. It asks, it just acts as a buttress or something. But what kind of suture do you actually use? I see it's a nylon. It looks like a Prolane. Is it a 5-0 or what size did you use?
Yeah, it's 5-0. It's 5-0 nylon.
5-0. All right. And, and the next question is, so now it seems, if I understood you correctly, you're doing this practically for all cases, also to keep up the practice of it, right? Or are you just doing it really for the grade 3 leaks where there is obvious a lot of CSF coming, or can you just clarify that point, please?
Actually, not only the grade 3 CSF leak, as I saw in the first 1 or 2 cases, is not CSF grade 3 CSF leak. It's probably maybe the grade 1 or grade 2. But if the patients have the condition of the suture, we can do more suture about it. Not only the CSF3 grade 3 CSF link, but yes, CSF3 link definitely we do the continuous suture.
Yes.
But in the grade 1 or grade 2, we have some kind of maybe 2 stitches or something. It's not
Right.
continuous. Yes.
So you just use 2 stitches to keep the whole graft system there in place, kind of thing, and then you put glue and whatever else you do, right?
Yeah, exactly. Yes. Yes.
Okay. So you don't routinely do this for all cases, the more elaborate. Then one last question. Your opening of the sella floor, the dura, doing these sutures, I mean, classical opening is sort of an H, another one is cruciate, and some people like to do a flap up away from the carotid, on and on. So what kind of opening does that influence your opening, that the way, since you're planning to do sutures?
Okay, he may have a delay in his.
Actually, there is. I think there's no influence about what we want to. Sorry.
Go ahead. Go ahead.
Okay. Okay. Yeah. I think it's we actually there is no influence about whether we want to do the suture and opening of dura. Opening dura, always do it in the same way, whether we do it suture or not. Before the suture era, we just open in this way, and after suture, we just give a open in the same way to resect the tumor. It's no difference for the dura opening. Yeah.
Great, Dr. Parekh, do you have any comments?
Hello.
Yeah, go ahead, Dr. Parekh.
Yeah, it's excellent demonstration of suturing in various grades of CSF leak. And yes, CSF, post-operative CSF leak is a real problem when it occurs, and it is really many a times we have to go in again and do it. And the suturing of the dura requires a lot of practice, according to me. And it's not easy that everybody can do that. I love your instrument, what you have shown. It technically looks very good instrument. One more thing, when you use a nylon suture, they are non-absorbable. So what do? Do you remove or do you leave it behind for a long time?
Actually, we just leave it here. It's not absorbable, but leave it. We leave the sutures here. We don't get rid of the surgery. Yeah.
Okay. And about lumbar drains, yes, I in my experience, I found lumbar drains works very well. What even we do in our practice is we do a graded drainage of lumbar drain. Means we don't do continuously. We drain the CSF every 1 hourly or 2 hourly, 10 ml per hour or 2 hours, so that this problem of pneumocephalus or hydrocephalus, which is coming due to the negative pressure created by drain, and that can be avoided. I have experience in few patients that they develop a massive pneumocephalus, and usually we don't do it. We make the patient flat and give a lot of oxygen so that this air gets absorbed. But lumbar drain does help to us in many cases. I agree, if your reconstruction is very good, then there is no need for a lumbar drain. Wonderful. The technique, I'm impressed with your suturing. It's very difficult to do it unless you are well practiced. You have to keep on practicing because you require a long instrument plus steady hands. You are going through one nostril or a bi-nostril, and your assistant should be able to hold the endoscope properly. It's difficult. But yes, you have shown very good technique. Wonderful. Great.
Yeah, actually, we built this kind of system for nearly 5 years. Nowadays, we master the kind of skill very good, but in the beginning, it's very time consuming. It's about 2 hours with construction time. It's not easy to go in on. So we insisted on this. So nowadays, I think before that, we always think it's possible to suture. Nowadays, we think it's the progress.
So you need to take a
We
proper
can-
flap of a dura when you have to do the suture. Good job.
Okay, very good. Okay, Dr. Kanu from Nigeria, are you
going
there?
from
Dr. Kanu, are you there? From Nigeria? Perhaps he stepped away. Any more comments, questions?
Thank you, John. I've enjoyed the session. I have no questions. I have no comments.
Okay, well, thanks for coming.
Thank you very much. I appreciate it.
Okay, Saeed, how about you? Do you have any comments or questions that you'd like to give? I'm bothering people. I'm waking them up. How about you, Dr. Brahani? Do you have any comments or questions? Perhaps he stepped away.
No. I'm listening.
Okay,
Just
good.
a great lecture. The suturing is nowadays they're using more and more. I think it is to be sure that your flap is fixed to place. It doesn't mean that you have to suture all around. Just put some wear in some clip, maybe is also helping, but this is a good technique. Also placing the fat inside and also outside in the sinus sphenoidalis.
Yeah.
So I loved this lecture. Very nice. Thank you.
Thank you so
for your
much.
question.
Thank you for your comments. Yeah.
Okay, any more comments, questions before we close? Very good. Another good interactive session along with Dr. Sbeih's first one. And thanks all you guys for coming. Thanks for using this platform to spread neurosurgery education. We had neurosurgeons from all over the world, India, Afghanistan, America. I mean, this is a great platform. It's going to get even better with Chat GPT. Get ready for Chat GTP. You guys, I never understood artificial intelligence, but man, oh man, it's going to change things. So, including Zoom. So stay tuned. Goodbye, everybody.